Shall we start, ma'am?
Yes, please.
Good evening, everyone. Myself, Dr. Deepthi Sriname, Assistant Professor in GMC Chandrapur. Thanks everyone for giving me this opportunity. Our topic for today's PG Star series is an important one, that is family planning and contraception. According to WHO, family planning is defined as the ability of the individual and the couples to anticipate and attain their desired number of children and spacing and timing of their births. To throw more light upon this critical and crucial topic, we have our esteemed speakers, examiners, our president NOF, and last but not the least, our PG student presenting cases on MTP. We all know that 10 to 13% of our mothers lose their lives, and many suffer from morbidities because of unsafe abortion, and many more due to unintended pregnancies. Sad to say that we also lost our dentist, Dr. Savita Halapnath, Denmark, due to abortion-related complications. Many processions regarding abortion laws are occurring in US, where abortion has been banned in 14 states, and France. France has now become the first country to enshrine abortion as constitutional right. So, to prevent deaths and morbidities due to abortion and unintended pregnancies, family planning and contraception play a critical role. Our aim must be to achieve zero maternal deaths due to abortion, unintended pregnancies, and STIs. To achieve this, we need to update our research activity, teach our PGs and doctors the importance of family planning and contraception, so that it percolates to the last human of the society. We must also strive for safe, timely, and affordable and respectful abortion care. Today's PG Star this topic is definitely going to enlighten us on this topic. So I request our dear President of Dr. Sushma Deshmukh Madam, who is luckily from Chandrapur also, to give her welcome address on this all important topic.
Thank you, dear. A very good evening to all. It gives me satisfactory feeling today to welcome you all for the PG Star series organized by Nagpur OBGYN Society with Government Medical College Chandrapur. Friends, this is our 21st PG series and last webinar of our tenure. We all know that since 1 year, we all are tuned with this wonderful PG Star series. We talked about infertility, we learned art of hysteroscopy, and we had gathered amazing tips of obstetrics. We solved gynecology with solutions and tricks. But what about the family planning and contraception? So we need to discuss it. So let's discuss it today. Now we all are here, all renowned faculties gathered here with us. But our patient selected Dr. Oshin Ramteke for her MTP. She wants to know all about it. So Dr. Oshin is going to present all options in front of her. Dr. Ganpat Sawant sir and Dr. Neema Acharya ma'am will add some brilliant tips and solve her problem. Welcome Dr. Ganpat Sawant, Dr. Neema Acharya and Dr. Oshin. But after MTP, this patient wants contraception and advice. Dr. Shobha Gudi, an amazing faculty, is having expanded basket of choice for her. And it's a great pleasure to listen her pulse of wisdom. Welcome Dr. Shobha Gudi. For this session, Dr. Jatinder Chadha and Anupa Walia Lokwani will share the session and will add some brilliant tips. Welcome Dr. Jatinder Chadha, Dr. Anupa Walia Lokwani. Dr. Deepthi Sriname has a very nice planning to put all the faculties and topics in a nice way. I welcome to all seniors, juniors and my friends for witnessing this wonderful webinar. You all know Dr. Anuja Bhalerao, Dr. Bhakti Guzar and Dr. Prachi Dikshit are strong pillars of this PG Star web series along with us. And today, our Enujius family with me and Dr. Pragati are really speechless. We never imagined, never thought that this PG Star will be super hit. And now we are witnessing its success. The wheels started rolling 1 year back when I discussed with Dr. Anuja, Dr. Bhakti and Dr. Prachi. And really all managed very well. So our stream, all brilliant faculties, these pillars and all UPGs. So today I'm feeling very satisfied for this last webinar. So dear PGs, though our ways are different, our meetings will be difficult. These golden moments are we are preserved in a special corner for heart. Send all the best for your successful future and next years, coming next years. So I would like to involve Dr. Bhakti to say a few words, Dr. Anuja, if she's there, and Dr. Prachi. Really, the whole year was really filled of so many wonderful webinars and amazing academics that we all witnessed. And really, we are really happy. Even everywhere we used to go, our PG used to come and used to say, ma'am, this PG Star webinar is very nice. And really, we are very happy. And that was our purpose, to spread this wonderful knowledge of all these faculties to each and every PG student. Thank you very much.
Now I request our second year PG student from GMC Chandrapur, Dr. Oshik Ramtekri, to present her case on MDP. Examiners for the same are Dr. Ganpat Sawant sir from Mumbai and Dr. Nima Acharya madam. Dr. Ganpat Sawant sir has been the former HOD and professor of D.Y. Patil Medical College, Navi Mumbai, director of Noble and Noble Plus Hospital, Ghatkopar, Mumbai, ex-president of Ghatkopar Medical Association, Mumbai, president-elect IMA branch, Mumbai. He is a senior committee member of Mumbai Obstetrics and Gynecology Society. He has received a prize twice for the best committee member in Mumbai Obstetrics and Gynecology Society, and passed his UG and PG from prestigious ZGS Medical College and KM Hospital, Parel, Mumbai. And regarding Nima Acharya madam, madam has experience of more than 20 years in UG and PG teaching. She has been the recipient of Korean Research Award 2013 Proctoring. She has been the past president of Datta Meghe Vardha, then trained in advanced training in infertility and gynecological endoscopy, head of the gynecological endoscopy unit, Acharya Vinoba Bhave Rural Hospital. She has been the editor and author of more than 10 chapters in OBGYN textbooks, member of GCPR and MDIP committee FOXY, editor of book on OSCE, that is the new CBME curriculum, and she has under her name 200 research publications as author and co-author. Welcome, ma'am and sir.
Okay, that was very nice. Can I make few comments?
Yes, for sure.
Yeah, so first of all, thank you very much for involving us and inviting us to take this exam on the topic, which is so basic and so important. Because when we joined our MD, that time it is to be bread and butter for the gynecologist. And today also, I feel that's one of the basic surgeries everyone has to learn about it. Because the number of complications which we sometimes face, they are such a life-threatening and they are very difficult to manage. So it's a very important topic. Coming to what Deshmukh Madam has said, and congratulations for completing such a wonderful year. In fact, I would say, like, Jasa Raja Tasi Praja. So you yourself being a so nice body and taking care of all OBGYNs and these students so well. So I think the students will do much better. And it's good that you have included as a basic topic for this. So yes, a stage is yours and you can take it over.
So by the time she's carrying us, yeah, she shared. Okay.
Good evening, everyone.
Yeah.
First, I would like to present first trimester medical termination of pregnancy.
Be little bit larger, louder, little bit louder.
Yes, sir. So this is a 28 years old female, Mrs. S, is a second gravida with 2 months of amenorrhea, resident of Mool, is a Hindu by religion, studied till 8th standard. She's a homemaker. Her husband studied till 10th standard, farmer by occupation, came to the hospital for termination of pregnancy. History of present pregnancy. Patient was apparently asymptomatic 1 week back, had complained nausea since 1 week and increased frequency of micturition since 2 days with history of 2 months of amenorrhea. She conceived spontaneously during lactational amenorrhea. Pregnancy was diagnosed by UPD at nearby Anganwadi center. Then she came to GMC Chandrapur for termination of pregnancy. Pregnancy was confirmed by USD at 8 weeks of gestation. At her first antenatal visit, all routine antenatal investigations were done. Her obstetric history. She is married since 2 years. It is a non-consanguineous
So
marriage.
1 minute. When are we supposed to ask questions? In between or at the end? Sushma madam?
Sir, you can interrupt anytime. You can ask questions anytime.
Okay. So first of all, then in this case, patient was, how did she come to clinic? Because she is a lactational amenorrhea, isn't it? So why did she come to hospital? Usually they feel there is a amenorrhea because she is breastfeeding the child, and they feel it's a amenorrhea because she is breastfeeding the child. Is that history correct? What I am saying?
So actually, she started having nausea and increased frequency of micturition. So that's why she visited hospital to clear her doubt whether she is pregnant or not.
Very good. So at least she had that thing in mind. If there is a nausea and vomiting, she was suspecting that she could be pregnant, and that's why she came. Okay, very good. And why did you do sonography then for this patient?
Sir, to confirm her pregnancy, whether it is an intrauterine pregnancy or it is a live pregnancy or not.
Is that a proper reason or that is correct? But you must have done PV examination, size of the uterus, most plus is asymptomatic. So in lactational amenorrhea, why we do sonography? There must be some specific reason, because for all MTPs we don't do that.
Can we go to the previous slide, beta?
Put it on slide mode.
So here, she has delivered how many months back? Second gravida with 2 months amenorrhea, right? See, there is little bit confusion in your history. On one side, you are saying that there is lactational amenorrhea, and then you are saying it is 2 months amenorrhea, isn't it? So, what is the history, obstetric history?
Yes, now she is day 2 given everyone. She is
Just go ahead.
Just to give the
Go ahead.
Just to give the explanation, sonography is correct because sometimes in lactational amenorrhea, patients might say 2 months or she might be pregnant for 3 months, because usually in lactation, it does not match with the number of months what she is telling. There could be some spotting only, which she might interpret as LMP and all those things. So those who have a regular period, we can depend upon patient's history. For those who have an irregular history, it is better to do sonography to document how many weeks she is. That is a more precise reason. Yeah, you can go ahead. No problem. Continue, Vita.
Obstetric history. She is married since 2 years. It's a non-consanguineous marriage. Second gravida, she's second gravida, para one, live one. First live birth is a full-term female child delivered vaginally. Antenatal period was uneventful. Her postpartum and postnatal period was uneventful. No any contraception was used postnatally. Her menstrual history. Her last menstrual period is 16th January 2024, and her expected date of delivery is 23rd October 2024. And accordingly, her gestational age is 8 weeks, 2 days. Her past menstrual cycles were regular, 3 to 4 days of 28-day cycles with soakage of 4 pads per day, not associated with dysmenorrhea.
So what is missing in your this slide in your obstetric history? What is the age of this child?
Around 9 months.
You've written here.
Mhm.
It's missing, no? So always write. Make a proper format in exams, otherwise you'll forget. So you should have a proper format in your mind that what all things you're going to write in each pregnancy outcome, right? After obstetric formula, what are you going to write about each, isn't it? Because that duration of lactational amenorrhea, everything should correlate well, right? Okay, go ahead.
Coming to the second thing is, in exam, you will not have such a big time or long time to present. Today it's okay. So you must talk very focused presentation. For example, here in this case, we did not talk about whether it's a consanguineous marriage, whether there was any other history, because it's a straightforward 2 months amenorrhea on whatever no history of so the previous periods were regular, which you should have said and all those things, and go to the next, because in few couple of minutes you have to finish, and somehow you have to reach the diagnosis and treatment to fetch the maximum mark. So today it's there good because we are there here to discuss each and every point, but I think it is better to keep it in mind in final exam. Go ahead, please.
Past medical history, no abnormality detected. Past surgical history, no history of surgical intervention in past. Family history, there is no history of hypertension, diabetes, or any other major surgical illness in family. Socioeconomic history, patient belongs to lower middle class as per modified Kupuswamy scale. Dietary history, patient's calorie intake is 2230 kilocalorie per day. Protein intake is 50 grams per day, and calorie deficiency is 300 kilocalorie per day. Her personal history, patient takes mixed diet. She is having good appetite, normal bowel and bladder habits, no any addictions or any drug allergy or any drug exposure. That's her examination. On general examination, patient is moderately built, moderately nourished, height is 150 centimeter, her pre-pregnancy weight 54 kgs, and accordingly her BMI is 24 kg per meter square. On examination, she is afebrile, pulse 84 beats per minute, which is regular in rate and rhythm, normal in volume. There is no radio-radial delay, radio-femoral delay, and all peripheral pulses are well held. Blood pressure, it is 110/70 millimeters of mercury, taken in right arm and sitting position. Respiratory rate 50 per minute, JBP not raised, orodental hygiene maintained. There is no pallor, icterus, cyanosis, clubbing, or generalized lymphadenopathy, and hyperpigmented knuckles are present. There is no edema, nails normal, deep tendon reflexes normal. Systemic examination, CNS patient is well oriented to time, place, and person, and she is cooperative. Cardiovascular system, S1 sound, S1S2 present, no murmurs present. Respiratory system, bilateral air entry present, and no adventitious sound heard. On per abdominal examination, abdomen is flat, linea nigra, striatum present, umbilicus is inverted, honeyal orifice is intact. On palpation, after obtaining verbal consent and voiding of urine, per update is soft and non-tender. On per vaginal
Okay,
examination,
now can we wait here? Now see, somebody has informed us this case is about MTP. If nobody tells us this case is about MTP, and if you are directly presenting the case, we will not understand what you are presenting for. For example, if you take the same case in exam in final, if you start talking about whatever you are saying, one examiner will think this is the case of this whether central cardiovascular system. Somebody will start thinking about its anemia because you describe diet so well, plus how much calories he is taking, proteins he is taking. Then somebody will talk about JVP, you said, so there are so many things. And coming to this per abdominal examination, you have said about there is abdominal flat, but linea nigra stria gravidarum is present. Now, what is stria gravidarum?
during pregnancy days,
In pregnancy,
The white lines around the abdomen.
those are not stria gravidarum. They are something else. Stria albicans. Stria gravidarum is the present pregnancy pink lines which are seen during the pregnancy. They are seen because of the stretch marks of the recent pregnancy, isn't it? Stria gravidarum is because of the present pregnancy. See, if you do not write, it's well and good. But if you write and if some examiner catches you on that point, because these are pink lines, white lines are
Previous
evident
pregnancy.
previous pregnancy after healing of stria gravidarum. That's the mark which shows she was pregnant in the past. Just you can make a point of all these things and can go ahead. Go ahead, please, unless madam wants to make a comment.
Go to previous slide. Why have you asked about this past history, cardiovascular examination, CNS, RS? For any case, forget about this MTP. Why are we asking this detailed history of past history, family history?
I mean, every ANC patient, it is important to rule out there are any heart disease or not, or there are any family history.
So the overall word which we use is, are there any comorbidities which the patient is having, isn't it? And why do you do general examination? You can directly do PSPV. No, why do you need general examination?
I mean, it will give a basic idea of the patient's vitals.
So general examination gives you idea about what the overall fitness of the patient, isn't it? Is the patient fit for pregnancy as such, and maybe whatever procedure if at all she's going to get, isn't it? Aage?
It's like, no?
Yeah. Proceed wherever you were. Yeah.
On palpation, after obtaining verbal consent, voiding of urine, per abdo, it is soft and non-tender. On per vaginal examination, cervical os is closed, cervix is firm in consistency, and it is posteriorly placed. Uterus is anteverted. It is of around 8-week size. Bilateral fornix is free and non-tender. Then provisional diagnosis. It is a case of 28-year-old gravida to para-1 live one with single live intrauterine pregnancy of around 8.2 weeks gestational age, came for termination of pregnancy.
So in your
Why
history,
do you want? Go ahead, madam. Yeah, sorry.
so somewhere in your history, there should have been something about, that patient wants MTP. Instead of, everything which you have written in history, that, patient's sonography was done and she had come to you like that with USG
Yes,
report.
at the first, I mentioned that she came for termination of pregnancy.
Okay, she has come for termination of pregnancy, right? So certain points in history need to be improvised, right? And in per abdomen and then PS, PV has to be done in detail. So you just can't write, per abdomen soft non-tender, right? If you're writing everything in detail, write properly. See, in exams, there is nothing like short case, long case. I always say every case has to be written in a long manner, examined in a long manner, because you have to thoroughly see the patient. If you have to present as a short case, you present only the salient features, right? So examiner can ask you anything. No? So where is the PS finding, beta? There is no PS examination, isn't it? So there should be PS per speculum examination findings. They may or may not be relevant to your case, but it has to be there on exam day because we are preparing for exams. You should know. Per abdomen also no organomegaly, no pre-fluid, bowel sounds are present. All those things, hernial orifices. Everything you mention in exam, if somebody tells you, like you tell me just the positive findings, just mention the positive findings, right? So make a point that per speculum examination, PV examination, right? All those things are mentioned properly, right? Then what about, uterus is anteverted, anti-flexed, soft, all those points, Make it a proper, detailed description of uterus. Make a habit that then only you'll be able to, give proper description and then differential diagnosis. Every point has a differential diagnosis to it, right? Okay, go ahead. So please.
Yeah, go ahead.
Then second trimester.
No, before that, this patient you said has come for MTP means what? Patient will not come and say, see, I want MTP. He must have said in our language. What did she say?
So she said in the Marathi language कि खाली
हाँ
करना
तो बोलिए ना मराठी. We understand Marathi, no problem.
So उसे खाली करायचं आहे, ऐसा बोला उसने. She said
हाँ तो का खाली करायचंय?
as a first baby is small, and that's why she want to discontinue the pregnancy.
So here comes your obstetric history, isn't it? You have not written the age of the child, isn't it? So what is the age?
So whatever you said, yeah, whatever you said is correct, but is that a correct indication? That's a very important point. What she is saying and what you are saying. Patient says, मला आता हे बाळ नको आहे, म्हणून मला साफ करायचंय. Is that a correct indication?
Does it fit
I hope
into the indications?
I hope you understand what I'm saying. की मी मला हे बाळ नको आहे, पहिलं बाळ छोटं आहे म्हणून मला हे अबॉर्शन करायचंय. So what indication is that patient does not want child, that's why we are doing it?
On first on maternal interest and second because of the socio-economic status and mental health of the mother.
Now you are enumerating the causes for MTPs. So when you fill the form in your institute, what point you tick when these patients come for MTP? Socioeconomics is quite good. What you have presented as dietetic history is getting good proteins, 50. Even we don't get sometimes that much. Calorie was 2,500 you are taking per day. You are lower middle class. Now see, this is how you are inviting trouble because you are given so much in detail about diet. She is not poor lady. I mean, she is not starving.
Have you ever filled the MTP documents? Then you will understand it, isn't it? So you have to tick on a particular indication, isn't it? So this patient, where you want to fit her into, or you want to counsel her for something else?
Because tomorrow anybody will come and say कि नहीं ये terminate करो. In short, in a crude language, I will say कि मेरा बच्चा मेरे पेट में है, उसको मार दो. So that is not the indication. None of the places that indication is there. When the baby is healthy inside the uterus, which you have documented on sonography. You have done sonography, 8.2 weeks healthy single live intrauterine pregnancy with yolk sac seen. The law will not allow you to terminate unless there is a proper indication. If you do not know, then next time you better find it out, but you can't write it down that way. Let's discuss at the end what indications it should be. Otherwise, if you know just now, you can say it, or we'll go to the next slide.
Go to next slide, beta.
And shall I start?
Yes, yes.
Yeah, please go ahead.
Second trimester MTP. A 23 years old female, Mrs. P is a primary gravida with 5 months of amenorrhea, resident of Gadchiroli. Her husband studied till 8th standard, farmer by occupation, came to GMC Chandrapur for routine antenatal checkup. History of present pregnancy. First trimester, she conceived spontaneously after 3 months of marriage. Pregnancy was diagnosed by UPT at nearby Anganwadi center after missed period. She's a registered case at GMC Chandrapur. Pregnancy was confirmed by USG at 12 weeks of gestation. NT scan not done. Double marker screening not done. She had a total of 2 antenatal visits, and all routine antenatal investigations were done, screened for diabetes, received folic acid tablet regularly. There is no any history of nausea, vomiting, burning, micturition, fever, bleeding per vagina, no history of any drug intake or hospital admissions or radiation exposure. Her second trimester, she received 2 doses of TD, first at 15 weeks of gestation and followed by second dose after 4 weeks. She was on regular hematinics and calcium intake from 4 months of gestation. Anomaly scan was done at 5th month of gestation, which was suggestive of multiple congenital anomalies, which are left club foot, omphalocele, scoliosis with left, which are towards left, and fetal sacral meningocele. Quickening felt at around 5th month, BP readings within normotensive range, no history of any fever, breathlessness, burning, micturition, pain in abdomen or swelling over limbs. Then her obstetric history. She is primary gravida, married since 11 months. It's a consanguineous marriage, second degree. Her menstrual history. Her last menstrual period, October 25th, 2023, and her expected date of delivery is 1st August 24. Her gestational age is 20 weeks according to EDD. Age at menarche 13 years. Her past menstrual cycles were regular 3 to 4 days, 2 to 3 pads per day soaked, not associated with dysmenorrhea and passage of clots. Past medical history, no past history, there is no any other comorbidities. Past surgical history, no history of surgical intervention in past. Family history, there is no history of hypertension, diabetes, or any other disorders in family. Socioeconomic, she belongs to lower middle class as per modified Kuppuswamy scale. Then general examination. Patient is moderately built, moderately nourished, height 154 centimeter. Her pre-pregnancy weight is 56 kg. Pre-pregnancy BMI 23.4 kg per square, and her pregnancy weight gain is 3 kgs. On examination, she is afebrile, pulse 84 beats per minute, regular in rate and rhythm, normal in volume, no radiofemoral or radio-radial delay, and all peripheral pulses well felt. BP 110 by 70 millimeters of mercury in right arm in sitting position. Her respiratory rate 15 per minute. JVP, there is no pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy, no edema, no edema present. Then a systemic examination,
Okay, go
CNS.
ahead with the per abdomen.
Per abdomen. On inspection, abdomen is longitudinally ovoid, linea nigra, stria gravidarum absent, umbilicus flat, hernial orifice is intact. On palpation, fundal height corresponds to 20 weeks of gestation, external ballotment present. On per vaginal examination, cervical os closed, cervix firm in consistency, cervix is posteriorly placed and bilateral fornices free. Then her probable diagnosis from history and examination. She is 23 years old, primary gravida with single live intrauterine fetus of 20 weeks gestation with multiple congenital anomalies.
Any other information you want to give in ultrasound, which the report you told? Most important information?
NT-NB scan.
No. The anomaly scan which you narrated.
Gestational age, amniotic fluid index.
So you have not mentioned anything about it, no?
Yes, ma'am.
Why it is important?
Ma'am, since oligopolyhydramnios are associated with multiple anomalies.
No, for your MTP case. Because she wants MTP, no, now.
Ma'am, gestational age.
Is it important?
Yes, ma'am. For termination of pregnancy, gestational age is important.
How?
Ma'am, because according to the MTP guidelines, up to 24 weeks of gestation, we can terminate the pregnancy.
And what about up to 20 weeks, below 20 weeks?
Up to 20 weeks also, We can
Is there
terminate.
any difference?
Ma'am, up to 20 weeks, we can terminate on maternal request or all that indications, but up to 24 weeks, only two indications are followed. Like first is multiple anomalies, and second is serious pregnancy caused by rape.
Okay. So, sir, please go ahead.
So see, now you presented so many slides where not, I mean, at least personally, I feel you have presented what you presented in the first case. So that's what my this thing was. You must talk to the pertaining to the your case. That's one. Second thing, the hint should be in such a way that is a 20 weeks. Just now you have said. So why anomalies are there in the NT scan was done in this patient?
No, sir, anti-scan was not done.
Okay. So if NT scan would have been done, what do you think? Does this what do you say? This anomalies could have been detected earlier?
Yes, sir, we would have gone to the much more invasive test to detect any anomalies.
No, we are asking very Chandrapur. You are saying Nagpur is here. Don't say that. I am asking if your NT scan would have been done, would you suspect anomalies beforehand? Invasive, why you want to? You are in dilemma, then you have to do invasive.
Basically, sir wants to know NT scan predicts what and whether it would have been helpful to predict कि ये सब बाद में होने वाला है.
No.
Correct. Yeah, पहले it could have suspected because the anomalies which you described here, they are gross anomalies. Like spine is scoliosis, kyphosis, so many things you have said. So that on NT scan definitely we can able to make it out nicely. Plus NT का मतलब ही क्या है? So there are so many things we could have suspected at least, and we could have detected this earlier. If you say we cannot detect at NT scan, then that NT scan is not done by the person who is fetal medicine foundation expert. And that's why now doing a sonography by the foundation expert is so vital. So it is not only to present the case, it is we have to have some take-home messages as this patient needs NT scan. Apart from that, if the patient is coming for your follow-up, how will you suspect something is going wrong? Anything on clinical examination, you suspect that something is gone wrong with so much of gross anomalies. Okay, coming to the straightforward point, there will be definitely abnormalities of the uterine size because of the amount of liquor which is present around the baby. If so many things are there, there is going to be polyhydramnios. Uterine size will look much bigger, and we need not wait for anomaly scan. You can get it scan done earlier also. What is we called as detailed sonogram, or we can call it as early anomaly scan, which can be done at around 16 to 17 weeks, and then you can avoid all the further complications. So anyway, so till this point you have presented, patient is with you. Now, doctor, what should we do it? So go ahead for the next thing. With this anomalies, is this anomalies compatible with life?
No, sir.
No, sir. So whether the patient says, I want to continue pregnancy and you feel this is non-compatible, how should we go ahead? Because she doesn't know what is it. She comes
Sir,
with this report in your OPD and then you are there with 20 weeks of this report. How should we go about?
Sir, I'll try to counsel the parents that the baby will be born with severe anomalies, with abnormalities, which for that the baby will remain handicapped for the rest of the life. The baby won't be able to do her on all the normal day-to-day activities. Will take pediatrician opinion.
This is the standard answers we get everywhere, but we need to think also because baby has got so many anomalies that handicap, lifelong, all those things will be afterwards. I don't think this baby will be surviving. In fact, I think this baby will be stillbirth. If it delivers vaginally, look at that. You said exomphalus, the omphalocele. scoliosis, lateral curvature, fetal sacral meningocele. In fact, only meningomyelocele itself is babies have difficulty. So this is non-compatible straightforward. He says, okay, doctor, if you feel it's not compatible, we want termination. How will you go ahead with the termination?
Uh, First, I'll
If you
do all.
have next slide, you can present or you can go ahead. But we will focus on today's topic. We want to go ahead with termination. How will you go ahead?
Sir, first I'll do all the routine investigations. We'll send blood labs for hemoglobin estimation, grouping, RH, isomerization. Then after all the investigations, I would like to do medical with
Let's be little specific. I will do all the investigations, and you said only hemoglobin and RH isomerization. Anything else you want to do?
serological test.
So I will say like this, कि I would like to do following test. I will not say all the tests. If you say all the tests, I might say CT scan भी करोगे brain का. No, that will not be applicable. So what we will say is, I would like to do the following investigations for this patient. For example, hemoglobin to find out whether she's anemic, blood grouping and RH typing to find out whether her blood group, whether she's negative. In that case, I have to do husband's blood group also. These two things you said. Anything other investigations to this patient?
Then all serological test, HIV, HBsAg, VDRL.
Okay,
Then blood sugar level.
right.
Then urine routine microscopy and culture sensitivity.
Culture sensitivity
Culture
for
क्यों
what?
रे?
Sorry, urine routine microscopy.
Okay.
हाँ तो आप सोचिए just don't you think because you will be consultant ना after passing. Okay, go ahead, go on talking and go on proceeding with the MTP. Proceed with the MTP.
So the
Sir,
reports have come now. आगे?
sir, if the reports are within normal limit, I would give her mifepristone 200 milligram on day 1 itself, followed by extra amniotic saline
This
instillation.
is on OPD. This is OPD or indoor?
Sir, I'll indoor the patient.
And
बोलना
do what?
पड़ेगा. You have to take consent. बोलना पड़ेगा. You will have to do all those things.
It's a
I
big
will give this.
medical this thing, no procedure. So what all formalities you'll do before you proceed with all this, beta? Tell that.
So I'll take the consent. I'll fill up the form 1 and C, all the MTP forms. Take consent from both mother as well as from the husband. Husband consent is not required, but still will be taking. And after taking consent, we'll proceed with the MTP procedure.
If the gestational age is 21 weeks, right? Say you are not given gestational age here. So what you would have
20
done?
weeks.
Yes, ma'am.
अगर 21 weeks है तो क्या फर्क पड़ेगा?
मैम 2 डॉक्टर्स नहीं, 2 डॉक्टर्स लगेंगे मैम, 2 डॉक्टर्स साइंस लगेंगे.
एंड इंडिकेशन क्या आएगा इसमें?
Indication, ma'am, baby born with serious injury to the baby, born with anomalies, physical and mental abnormalities.
Okay, and then what else you will feel? पेशेंट का कंसेंट फॉर्म क्या क्या होता है?
Patient का फॉर्म सी मैम, फॉर्म 1.
फॉर्म 1 क्या होता है और फॉर्म सी क्या होता है?
फॉर्म 1 is certificate of opinion and form C is consent.
कंसेंट पेशेंट है ना? तो कंसेंट ले ली, फॉर्म 1 हो गया और फॉर्म ई आता है beyond 20 weeks, right? Where 2 practitioners, registered medical practitioners, have to give their opinion. And then that form also gives you which exact indication under which it can be done, right? And then you've done form C. Anything, any other formality, biggest formality which you have to do? Where do you enter? Where do you admit the patient? On the document point, I'm asking. Have you seen admission register? आपके यहाँ जब एडमिट होती है एमटीपी की पेशेंट, इज देयर एन एडमिशन रजिस्टर विथ योर CMS or HOD or what is form 3? Have you ever filled that 16 column register? देखा है ना? So that is form 3 or admission register, isn't it? वो करेंगे कि नहीं?
Yes, ma'am.
तो ये सारी फॉर्मेलिटी किए बिना you should not move ahead, isn't it? आगे फिटनेस हो गया, डॉक्यूमेंटेशन हो गया, देन ट्रीटमेंट.
We'll proceed with the procedure, ma'am.
Proceed, please proceed fast. We got 10 minutes left.
Sir, we'll give her mifepristone on 200 milligram on day 1. I'll do medical method, ma'am. I'll go with the medical method.
Okay.
Then followed by after 48 hours misoprostol 800 microgram vaginally, and then we can repeat 4 hourly misoprostol 400 microgram. Maximum 4 doses can be given.
Is 21 weeks, na? 20 weeks, na?
Yes, ma'am.
What is the protocol?
So, in second trimester, we either medical method or by extraamniotic ethacridine lactate or extraamniotic instillation with transcervical balloon catheter.
Okay. So
What
how will
is the
you
color of ethacridine lactate?
Bra, bra, mhm. Bra.
they must not
Somebody
have
is
seen on you,
prompting.
sir.
So exactly, that's why you should not talk about that. No, ethacridine lactate is not available.
Available now.
And it is not at all brown color. The person who is prompting also is misguiding you. Brown is coffee जैसा हो गया. It is not that color. Ethacridine lactate is not available. What you are saying is correct. But why you want to give Mifi first and then Mizu? What is the logic behind that?
Sir, because of mifepristone.
Go ahead. Complete your sentences. Be loud and clear.
So it has anti-progesterone effect, which will help in, which increases the contraction, myometrium contraction, and will help in better expulsion of the fetus. And it
So
increases,
Mifi will help in contraction.
Mifi will help the process go faster with induction process.
Induction abortion interval will be less because of giving Mifi in the beginning. So Mifi being an anti-progesterogenic agent, it will help in separation of the placenta better, and it will help in a because of anti-progesterogenic discontinuation. Okay, so how do you expect that baby to come out with severe multiple congenital malformations? How do you expect this baby to come out? First of all, have you seen any abortion happening with such kind of babies?
Yes, sir. It's just like
Yes,
mini.
by
Okay.
bolo.
Mini labor. Okay. She's saying mini labor. Okay. So what happens?
Okay.
Ma'am, the cervical dilatation starts.
Hmm.
No, that is MBBS questions, MBBS answers. For PG, we have asking, at least I am asking, how have you seen first of all, then we will discuss. If not, then we will tell you. Because first of all, I am asking, how does the baby comes out? Of course, patient is labor, cervical dilatation, and everything is happening. Suddenly membranes are ruptured and sister calls you, doctor, something is coming out. So what do you expect? Which part of the baby you will expect to come out in this severely congenital malformed baby?
First, sir, in such cases, breech is the presenting part.
Very good. Next common.
Or maybe foot or
Very good. So you are saying that one foot is out and baby's buttocks are there around your fingers, you can feel it. Now what will you do? Patients
Sir,
are getting good contractions.
Sir, we'll wait for spontaneous expulsion of the fetus, or will augment the process by giving pitocin.
So how will you decide that to give pitocin or not to give pitocin?
Sir, by dilatation of the cervix.
I mean, this baby's leg is out, no, and buttocks are felt. That we are discussing this patient only. No, we will not discuss hypothetically. This patient is 3-4 centimeter dilated, all cervix is ballooned up. Mesoprost, when you use the cervix is really very, very ballooned up. It's thin. Lower uterine segment is very well formed. He's in pain. If you start more pitocin, there's not good idea. Yeah, you are correct. So go ahead. That's why I asked whether you have conducted such kind of things. Do you require full dilatation for this baby to come out, meaning 10 centimeter?
No, sir. No, sir.
No, sir. So baby will spontaneously come out. Baby comes out, and then what will you do next? What will
Will
do means because, uh,
the placenta expulsion?
no, you expect placenta to come out, but it has not come out. That's why sister has called you now. Baby is out.
The manual removal of placenta, sir.
Immediately.
We'll give pitocin to intramuscularly 2.5 units. After 10 to 15 minutes of waiting, if the placenta does not deliver out, we'll remove it by manually.
How much pitocin you say?
The intramuscularly 2.5 units, and in the IV drip, we can give 10 to 20 units.
And why intramuscular 2.5 units?
So that postpartum,
IV is better or IM is better? Which acts faster? Which acts faster, IV or IM?
If there is no active bleeding, whether you can wait or not for the placenta to come out.
ma'am, we can wait.
Yeah. So you can wait. So either you can repeat misoprostol or you can start an oxytocin drip, right? Provided there is no active bleeding as such, you can hold on, right? And wait for the spontaneous expulsion of placenta, right? Okay. Now coming to your
You
first
should
question.
always wait. You should always wait because there's no hurry. Why I ask is because that umbilical cord is very thin.
Thin.
Sometimes people try to pull it out, it breaks, and there are problems. And then after some time, you see that the whole placenta is separated and lying in the lower uterine segment, which you have to do PV and just remove it. But there is no need of MRP because that is not the indicated thing. It will be separating if there is no bleeding after some time. And as madam said, you can use misoprostol or pitocin, but the dose which you said is not appreciated at all, and your viva will go somewhere else.
There is nothing like intramuscular oxytocin, huh? You have
And
to
what is 2.5? 2.5 nobody uses in this thing. Okay, next, go ahead.
So should we go to her first trimester MTP because I think they are almost going to close now.
So I just want to know one thing from her is what is the difference in indication between the first case and this case? Because that's very valid point which you should know and you should have clear thought.
Sir, in second case, we are terminating because of the serious risk of life of baby born with mental and physical abnormalities.
Perfect, done. For first case.
Sir, first, because of the socio-economic status and on a maternal request.
So that's why I said tomorrow I request just kill him, kill her, anybody. Can I do it? I can't do that.
Sir, as she is in lactational period, she doesn't want to continue the pregnancy, which may hamper her health, mental health.
But
So
she's
that's
healthy, hale and hearty, doing well. Just because patient walks in for MTP, are you going to do MTP? No. She has only one child, no? Provided she says she's
Have
never.
you, have you, have you seen anybody having two children with a spacing of only 9 months or 10 months or 11 months or 12 months? Have you seen a couple where spacing between the two kids is only 1 year or 1.5 years?
yes, sir.
So same thing will happen her. She will say, okay, good. It depends. How do you think? मेरी family जल्दी complete हो जाएगी. Good. But as a doctor, you should know the termination why you're doing. Just baby is inside. That's why I am walking in and नहीं उसको निकाल दो. That is not the indication. That's why at least I am asking you so much in detail. If you do not know, then there will be problem.
Sir, even after counseling the patient, if the patient is still adamant that she doesn't want to continue the pregnancy, sir,
So how will you document it? How do you document that whether patient wants MTP or you have advised MTP?
because the patient wants MTP.
Because you
I-
PTs are always used to writing, advice, MTP. Are you going to write like that? So everything should be documented, that possibility of continuation of pregnancy was discussed, isn't it? All those things need to be documented, but patient is or patient wants this MTP for contraceptive failure or whatever indication you want to write, everything patient wants it. You're not going to terminate it because she's just pregnant accidentally, isn't it?
Madam has already given you the hint for the indication. If you have picked up well and good, if you don't pick it up, it is not a good idea at all. Because if she is so smart, she doesn't want pregnancy, then she should have been still more smarter and come to the doctor. Doctor, I don't want a further children, for I want spacing. That's what the definition introduction you said. That's what the family planning is for.
failure of
And then basically she should have been guided, which we usually guide patients after delivery before she goes to the husband's place. माहेरवरून सासरला जाताना तोच आंबे घालून जा. That advice we always give. If not, we should give it. But the indication is failure of contraception. She has used, even if it's not, we have to put it. There is no column like patient does not want this child. Indication ऐसा किधर भी नहीं है. So that thing should be clear in your mind.
And another thing is documentation also. Patient wants MTP, then you PGs always will write advise MTP. Admission ऐसा नहीं करना है कभी भी, है ना? You have to write properly and later on when you admit the patient in that admission register, where do you put all the entries? कहाँ कहाँ एंटर करते हो उसका नेम MTP का जब इंडोर होती है पेशेंट?
first there is MTP register book here, and then in the form 1, form C, form 1.
देन फॉर्म से तो वो भरती है, फिर इन दोनों का क्या करते हो?
Sent to the DGHS.
एनवेलप वगैरह आप लोग नहीं बनाते, कहीं भेज देते हो?
Ma'am, prepare the envelope, all the forms.
Hmm.
Then
Why
send
to
to
prepare the envelope?
एंड उस पे क्या लिखा रहता है?
No, I don't think she knows why you prepare envelope. Why do we prepare envelope? What are we talking about? Why this? So many things. Prepare envelope, separate MTP register.
all the data, all the data are sent to the district government health services. All the are
So for that you need to put it in envelope.
ये रजिस्टर आपके हॉस्पिटल में किसके पास रहता है? एडमिशन रजिस्टर
ये हमारी मेन
रहता है ना? तो अपन डिस्ट्रिक्ट अथॉरिटीज को तो मंथली डेटा भेजते हैं. दिस रजिस्टर इज अ वेरी सीक्रेट रजिस्टर. इट्स अ वेरी कॉन्फिडेंशियल रजिस्टर which has to be kept in the custody of the owner or the authority who's looking after the center, isn't it? और बाकी जगह नाम एंटर करना है क्या? हॉस्पिटल में उनका एक नर्सेस का बुक रहता है और उस पे डालना है पेशेंट का नाम कि नहीं डालना है?
नर्सेस की बुक
नहीं डालना रे बेटा. यू हैव टू कीप एवरीथिंग, है ना? सीरियल नंबर क्यों देते हैं अपन? And what do you put on the envelope? And what do you put it on the form 1? उसमें क्या डालते हैं अपन? सीरियल नंबर देखा है एडमिशन रजिस्टर में? Have you filled it? If you filled, you will know. Otherwise, your JR3 or somebody must be filling it. That's how you do it.
भरा उसमें नेम, एज, सेक्स, देन
उसमें सबसे पहला कॉलम रहता है सीरियल नंबर, है ना? वो सीरियल नंबर हम लोग एनवेलप में भी डालते हैं ना कि नहीं डालते? डालते हैं ना? हाँ, तो फिर सो एवरीथिंग इज सीक्रेट अबाउट दैट. वो किसके कस्टडी में होता है? जो ओनर है या जो भी अथॉरिटी जिसके अंडर वो रजिस्टर्ड है, isn't it? And it has to be shown to whom? It is not to be shown to anybody. Only whenever the district authorities, if at all they come to check the legal aspects of
एक
it.
महीने के बाद उसके हस्बैंड आके बोलते हैं मुझे दिखा दो उसके
दिखा दो
साथ
तो आप
किया
दिखाएंगे
है,
क्या?
तो आप क्या करेगी? विल यू शो हर द फॉर्म विच इज देयर फॉर द एमटीपी?
या कोई भी आता
कभी
है,
किए हैं
इनफैक्ट
कि
आपकी कॉलीग बोलती है कि मुझे दिखा दो थोड़ा, वो आई थी क्या, या किसी का फोन
आई
आया
सेड
था।
हस्बैंड बिकॉज वो नियरेस्ट है करके बोला था मैं, तो दैट
हाँ,
शी विल कम टू नो।
सो विल यू शो
तो क्या
दैट?
करोगे आप?
Because it is the responsibility of the person to keep it secret, confidential. बहुत कम टाइम है actually for 1 hour to discuss about MTP. It's a kind of, you're a part and parcel of that criminal process of killing that live baby, and it's a very big medical legal responsibility on us. Every effort should be made to continue the pregnancy, and if there is no choice, then only we terminate. Remember all that, and it is always from the patient's mouth. MTP should come, not from our mouth. Very rarely that word should come from our mouth. It should be a choice made by the couple or the woman. And it's a big legal responsibility to do any MTP because you're killing a life, right? So make everything very perfect document wise. Otherwise, next day you'll be on headline, you'll be in jail, right? So बहुत अच्छे से
कमिंग
समझो
फ्रॉम
legal.
From my side, doctor, you need to not only a good doctor, but you need to be aware because you must thank this Nagpur Obituary Society to keep this topic, because of which, in fact, we are telling you or we are making you aware so many things. Frankly speaking, you do not know, and it's not only doing MTP is important, but doing proper way MTP is much more important. That will save you. First of all, indication for the first MTP you are not aware at all. So it is the failure of contraception which we enter into. And then we have to tell patient it is a failure and you should practice that. Next time they should practice that one. Second thing, madam give you so many hints. Form 3, 16 column form. All these columns are for what? Basically to have proper record, maintain secrecy, those envelopes, even if you are not making envelope, not all hospitals they make envelope, but those papers are to be stored separately, and in the main admission book there has to be only MTP number so that it being a secrecy. Third thing, what you are saying, you submit data to authority, you don't submit the patient's name, you submit the number. First trimester, how many, second trimester, how many, all those things. We don't disclose anybody's name. And then basically you have to supervise because when you are doing this MTP, you are equally liable for all the consequences. Tomorrow, husband wife might come for to ask for all those documents, and then there could be dispute between the husband and wife, and there could be a lot of problems. Some patients will claim they are married, but they could be unmarried, and it could be boyfriend and girlfriend. So there are so many things happen, and that's why this law is so strict. Finally, your department has to be legally, what do you say, approved for MTP. Till date, we have discussed about only indications and procedure, but some of the places, if they are not legally approved to the MTP, you cannot do it MTP. And that's why this is very important topic. Not only that induction of labor, what we do it, but it is equally important to know the proper proceedings for this. So I will say this our webinar is eye opener for the at least residents or those residents who are listening to this. So from tomorrow onwards, have a look at all the books. At least you will come to know someone else is doing on our behalf that record keeping, which we should know in time. So thank you. Even if you have felt bad, sorry about it, but you need to know about it, and somebody has to tell you about all those things. So I think time is up, or whatever you people say, we can do that.
I would like to just tell the candidate that you keep presenting cases again and again. Every day you get a chance to improvise because after MBBS, no, you don't present for a gap of 1 or 2 or 3 years. So regularly do it. Let mistakes happen, but improvise every day. Make a proper format of how you're going to write each and every case, right from how examination points you're going to write specifically for abdomen, PS, PV, PR, everything. So you will not miss any point, right? And history is very important. You just can't casually write that deliver ho gayi. Age, there is a proper format. Every point has a valid reason why we write, why we ask all those points, right? And there is always scope of improvement. And even we don't know everything perfectly, right? It was all to share our knowledge and improvise yours, right? But you did a wonderful effort in spite of your busy schedules. So I wish you all the best and you'll do well. I am very sure. Sir is also very sure. So read about
Of course.
MSP. There are FOXY guidelines. So read about it. There is a complete booklet, FOXY Focus. It's fair. It बहुत अच्छे से दिया हुआ है उसमें, है ना? So read about it.
Yeah.
Thank you so much to NOGS for giving me this opportunity, and I thank Sir also for being a
And
co-examiner.
it's our pleasure. It's
Thank
our
you,
pleasure,
thank you.
madam.
Thanks a
Thank
lot
you very
to all
much.
the
Thank you.
examiners also and the presentator. It was really very nicely done. Can we have one group photograph? Please open your windows. We'll have one group photograph. Corona people?
Yes, ma'am.
Hi, Dr. Anupa.
Hi.
It is done. Mr.
Yes.
Ruchi?
Thank you, Bhakti ma'am.
Thank you, ma'am.
Thank you.
Thank you, everybody.
Thank you.
Hello,
Hi,
ma'am.
Dr.
Thank you
Anupa.
so much
Thank you
for the
so much.
wonderful discussion. Thank you, sir. Thank you, ma'am. Thank you so much.
Thank you.
Actually, Dr. Prachi and Dr. Bhakti, you must have a one word for this PG activity. All are here. Please express your views about this 1 year tenure. You did a really wonderful job for all the PGs. You know, they designed a complete protocol. They are just all the things. Please.
Thank you so much, ma'am. This journey of our PG Star, it started 1 year back when Dr. Sushma madam, she conceived this idea of connecting the PG students of Vidarbha region with all the experienced and revered teachers of not only Vidarbha, but teachers from all across the country. I think COVID has given us this wonderful idea of being able to connect to anyone. We did not have this concept before. So from the time of conception, we have tried to bring to the students a platter of all the topics of OBGY, right from high-risk COPS cases to gynec cancers, and now finally up to family planning and contraception. And today, as we come to the end of this series, we really have a feeling of this satisfaction, and we hope we have helped PG students, and I hope they are better equipped with for their examination with the inputs we get from our all very senior examiners. So I must thank Sushma Deshmukh madam and Pragati Kharatkar madam for always inspiring and guiding us. And I also thank Dr. Anuja madam and Prachi who have done a wonderful job of coordinating this CMA. Thank you so much.
Prachi, please, you want to say?
Same feelings from my side, ma'am. It was the coordinating all these sessions was a learning for ourselves too. We got to connect with the stalwarts, and we got the wonderful faculties on platform together. So this was such a great opportunity, and all the YouTube links which have been collected are going to be a treasure for us to share.
Yes.
Means it will take some time to update more, you know. So till then they stay back with all the students, and we'll try to compile and put them forward so that it can be used and watched by everybody repeatedly. I'm so thankful to all the faculties, and so thankful to your vision that you made this possible, because the perseverance to have it every 2 weeks and to get after everybody, to get the best of faculties, Pragati madam and Sushma ma'am, providing us numbers of all of them so that we could make them find some time for us and bring them on the platform. Thank you so much for that. Thank you so much,
actually, our
faculty.
first-
Dr. Shobha ma'am. Again, we have one of the great faculties, great examiners for today also.
Even today's also we are having wonderful faculties.
Yes.
So I am Kanpas sir, Dr. Anupa, Dr. Neema, all are really very nice.
Dr. Jatinder.
Yeah. And actually, in our first PG staff, we were having Andrea Tinelli from Italy. He joined from
Oh,
Italy to give the blessings, and he's a really wonderful academician. So it was our pleasure to have so many good people and good academician with us. Even this PG Car Connect, it used to reach even out of country also. So we
so
are
nice.
happy. Yeah, we had a good, very good response, and thank you for all the and. So our this last tenure also, this ending with the PG is a very good faculties also. I'm very happy.
I will
Thank
also
you,
like
thank
to
you.
share that we have had a cumulative viewership of more than 11,000 for the whole series and more than 6,000 YouTube views.
Very nice. Good. Congratulations to Nagpur OBGY Society.
Thank you.
Fantastic.
Thank you.
Mm.
Thank you so much.
Yes, sure. Dr. Pragati would like to say a few things.
Yeah, good
Just
evening
for
all. Good evening all. Really,
Okay. Very good evening to all. Really, this program we have done a battery of programs throughout the year. 23, 24 was full of activities for NOGS. But I tell you, this PG Star was my most favorite event because, through this star, first of all, we were spreading knowledge. We were having one-on-one good faculties from all over the country and even abroad. We had total 21 faculties who have delivered lectures. We had 42 examiners from all over India. We had right from Jammu to right till Chennai, we had faculties who have examined our students from Vidarbha. 8 medical colleges came together and they have organized this. So this was a celebration, a festival for all the institution. Now it's our turn to present, and all the presenters, they were so good. All topics were so well curated by our Dr. Bhakti Guzar and Dr. Prachi Dikshit. Thank you so much, girls. You have worked so hard and so systematic program. Then we had chairpersons from all over the country. Really, we had 42 to 50 chairpersons. And as Dr. Bhakti has said, our viewership total goes above 17,000. And because it's on the YouTube, the viewership is going to keep on increasing. And we get so many phone calls. PGs and even colleges are asking outside Maharashtra if they are so good programs. So we feel very satisfied and overwhelmed for conducting this important PG Star program throughout the year. And for today's program, I extend my heartfelt thanks to today's examiner, Dr. Ganpat Sawant and Dr. Nima Acharya for accepting our invitation and being examiner for today's program. Thank you so much, sir. Oshin,
Thank
you
you.
have presented your case very well. Thank you so much. From Chandrapur. Today, Chandrapur GMC was our co-host for this program. Then we have expert speaker from Foxy, Dr. Shobha Gudia. I know she's going to have a wonderful talk. And we have brilliant chairpersons, Dr. Anupa Valia Lokwani from Bhopal and Dr. Jatinder Chadda from Yamunanagar. And we are going to have wonderful discussion now. Last but not the least, all the delegates who always regularly log in, not only PG students, but practitioners and members from everywhere they log in. So I'm thankful to them. And Core Connect have been our core of support. So I wholeheartedly thank Core Connect people, RG, always making flyers on time and getting us. So it was so difficult to get pictures and put the topics and dates. And it was done so meticulously. Thank you, our Core Connect team. And last, Dr. Sushma Deshmukh. She's here with me and we are sitting in the office concluding our year and tenure. This was a brilliant idea and we have done it. I think we have done what we wanted to do, Sushma.
Yeah.
Thank you. So without delay, let us
You can
move
start
ahead
with-
for our talk.
Yeah.
Thank you so
Please
much.
start. Yeah.
No problem.
You can go ahead, Prachi.
Now I request Dr. Shubha Gudi madam to enlighten us on the topic of expanded basket of choice. The chairpersons for this session of Pearls of Wisdom are Dr. Jatinder Chadda madam and Dr. Anupa Walia Lokwani madam. I would like to introduce Dr. Anupa Walia Lokwani madam. She has done her MD from prestigious Institute of PGMR Chandigarh. She is currently serving as head and senior laparoscopic gynec surgeon and high-risk pregnancy consultant at Apollo Hospital, Bhopal. She is specially trained in high-risk pregnancy management and critical care obstetrics and is managing high-risk pregnancies and pregnancies complicated with medical and surgical disorders for the last 24 years. She has done her diploma in gynec laparoscopy and endoscopic surgery from Kiel University, Germany. She is an experienced minimally invasive surgeon and has performed around 3,500 various basic and advanced laparoscopic surgeries and passionate about minimally invasive surgeries. About Jatinder Chadha Madam. Madam is a consultant IVF and laparoscopic unit in Srijan IVF and Infertility Research Center, Chadda Hospital, Yamuna Nagar, Haryana. Founder President of Yamuna Nagar OBGY Society, Executive Member of and Editor of ISAR Haryana. She is also Executive Member of Haryana IH and practicing ART and laparoscopy for 20 years. She is a member of FOXY, ISAR, IFS, ESHRE, and National Coordinator for Pre-Congress Workshop on Hysteroscopy, ISR, Gurugram. She has also organized live operative workshops on endoscopy and infertility. Chadha Madam and Walia Madam. Can you hear me?
Do I go ahead and introduce the speaker?
Yes, ma'am, sure.
Okay. So, the speaker for today is Dr. Shobha N. Goddi. She is MD, DP, CIMP, and FICOG. She is a professor and head of the Department of St. Nas Hospital, Bangalore. Postgraduate teacher and examiner. She has been president of BSOG 2018 to 2019 and a board member of FPAI. I see that she has so many credentials to her, her profile. She is chairperson, contraception and reproductive health, ISO PARB from 2023 to 25. She is editor of Obstetric Hemorrhage, author of Foxy Focus, and she has had various publications, national and internationally. She has received award of CJ Jhaveri Symposium 2015 AICOG, Shri Satyasai Foundation Community Service for BSOG 2018. So, Dr. Shobha and we are, happy to have you as a speaker. Yeah. Over to you.
Thank you, Dr. Walia. Thanks a lot. And thanks to, am I audible well?
Yes, you are audible.
And is my screen visible?
Yes, it is.
Okay.
Yes, it is.
I am delighted to be here with NOGS. And though it is a little late in the evening, I do hope that I will make my point and I will be able to give few messages about the basket of choice available for practitioners today as far as contraception is concerned. So let me thank the Nagpur OB-GYN Society at the outset for inviting me. It is a real privilege to be amongst you. I have worked with Nagpur in the past, right with Alka Mukherjee, and also before that with my very dear friend Pragati also. And I'm not getting the name of that lovely girl.
Dr. Bhakti.
No, before that. Well, all the presidents before now, I have had the opportunity to work with them. And today, yeah?
Dr. Vaidehi.
Vaidehi, exactly, Dr. Vaidehi. So today I'm really particularly happy to be here at the behest of Dr. Sushma Deshmukh and Dr. Pragati Karaskar. And thanks to Dr. Walia and Dr. Chadha for chairing this session.
And I must say that I did not find it a problem to accept a late night session because it was Prachi, who was the intermediary. Prachi has really worked with me and I owe her so much. She and Dr. Anuja Bhalerao brought together a team for PPI UCD training. And even today, the sessions are remembered. And even today, actually, I was recounting our success with those sessions too in another webinar that we had. So thank you, Prachi, for all that, and thanks for inviting me here. So today, the world's population has exceeded 8 billion, of course, and these are stories we often keep on repeating, and we know that it will become 12 billion in another few years, and we also know that India cannot afford this because right now we have exceeded the population of China. Now this is the common man's perception when it comes to contraception. They feel that there are a lot of injection tablets and that copperty there and that rubber there, which is called the condom, and there are some methods to regulate the cycle, etc. And then some people can have a conversation like this also, where the patient asks the doctor, "ये property क्या होता है?" और डॉक्टर कहते हैं property के ज्यादा टुकड़े ना हो, उसको रोकने का यंत्र है. So it is in their minds it's very oversimplified the context that that it is just meant to prevent pregnancy. But in reality, contraception is much more. It is reproductive freedom and it is a fundamental right for the woman, and it is very, very critical for her reproductive health and for the health of the family. So when we look at few facts like this, it's very our understanding will become stronger if we realize that India has surpassed China. It has become the most populous country, and the figures on the right side are a bit old. So today, as China is not much more than 1.42, but we have changed from 1.362 to 1.44 billion. And that is how it goes. We stand as the most populous. And but we are only around 17% of the total. We are 17% or 18% of the total world population. But in terms of surface area, we occupy about 2% of the land and 2.4% of the land. And that should give us a huge concern that it is going to be increasingly difficult. And already the water scarcity is actually hitting all the cities. Bangalore is in the middle of a very bad water crisis. So similar things will happen to other resources as well. The day is not far when every common man will understand that limiting family and having fewer children is for the greater good and for the good of the family. But till such time, the role of the obstetrician becomes extremely, extremely important, because we must understand that there is a huge medical need for contraception. The unmet need is still very, very high. And given the huge number of pregnancies in India, 48.1 million pregnancies, an average per year, around 26 million births, 27 to 28 million births per year, and abortions are happening in 1/3 of these pregnancies. We need to understand very, very certainly that at any given point of time, half of the pregnancies are actually unplanned, are actually unintended, and most often are unwanted, not only by the couple, but even by the family. So the unintended pregnancy stands at a huge 48%, not only in India, but also globally. And what happens to this unintended is, the 33% end in abortion of them. So that is what is a huge reproductive wastage, which we looked at. And the estimated rate is 70 per 1,000 women in reproductive age. And if good contraception and family planning services are existing, then this number should come down to less than 15 or less than 10 per 1,000. So having set the background, let me quickly go through what methods can be offered, and essentially modern methods should be offered. And if we have good service provision, more than 70% of women are very satisfied And the unmet need, therefore, is just 15 to 19% even today. And the contraception prevalence rate is just 40% amongst women, whereas it should be around 70% in order to achieve any population stabilization of good degree. And increasing the choice will increase the acceptance, will increase the uptake, and will increase the cultivation. So we need to understand that. And this is typically what is there in the public sector basket today. All of us know this list. We all know that in this list, a few things are missing and we can add. And that is the non-hormonal pill, which is the Chaya, which has come, the implant, which has come now, a female condom, which is there in the private sector, and the natural methods, which one should never forget, because sometimes women do not accept anything at all, and then something is better than nothing. This is a chart which is very critical to every practitioner, should have it xeroxed or laminated and keep it in your clinics and show it to women when you're offering them contraception. Show it in a way that the arrow points towards you, and the woman can easily see what is least effective and what is most effective, and can easily see that LARC methods are very valuable for her. And after that are the hormonal contraceptives, etc., like that, so on and so forth. On the right side are these tips which tell us how to make the method most effective. And if you could blow up these charts and put them on the clinic and in the waiting room where women can read even as they're waiting for your consult, I think these things matter a great deal. We come to some of the methods which are commonly used today and which add to the basket of your choice, which you are going to offer. Now, these are data which are not from our country. This is from StatPulse, right? That means essentially it is from the Caucasian population, Western world. You can see that 25% of women are using OCP. In our country, it is merely 2 to 3%. And this is such a wonderful method that more women can. So there's a lot of, there's a lot of potential for increasing the prescription for oral contraceptives. And we have the combined, we have the progesterone only, and we have the low dose combined to be given as continuous or extended feed use, or for which there are good medical indications. And all of us must understand, how they work. So that while prescribing, one has enough courage, enough conviction to say that yes, this is going to prevent pregnancy and it is not going to harm. It acts on the endometrium, it acts on the higher centers, it acts on the cervical mucus, and more interestingly, it acts on the liver and increases the SHBG, facilitates the metabolic clearance of testosterone by decreasing the free androgen index, because it increases globulin synthesis in the liver. Mainly the estrogen component does that. And when SHBG increases, it binds to all the free testosterone. And you all know that this is of vital importance when we prescribe these medications in women with polycystic ovarian disease with hyperandrogenicity. So there are a lot of benefits like this hidden inside that pill strip which you prescribe, which you will understand as you go on increasing the prescription. The evolution of oral contraception should be well known to all of us. We must know that with every change in availability, more safety factors were added, principally by reducing the amount of estrogen present in it from more than 50 to the ethinyl estradiol came down to 30, from 35, and today even 20 and 15 are available. But of greater note is the change in the type of progesterone which has been changing from levonorgestrel to the better ones, desogestrel, to even better ones, drosperinone and dilagest, with its tremendous benefit. So we need to understand the generation of progesterone. And this is another slide which I have already spoken about. So shows the traditional regime, which are today 21 and 24 days. And this 24 days is the new one, and practitioners need to understand why we increase from 21 to 24, and that is to reduce the number of hormone-free days and increase the benefit and reduce the lower of estrogen each day, so that the amount of estrogen circulating in the blood becomes lesser, just by extending 3 more pill days. The extended regime extended regime are of tremendous benefit. We give 3 to 4 cycles and then give a break. And the continuous regime uninterrupted up to a year. And these are methods which have been followed in the Western world for several years now. But the concept is recently developing here in India. And though we do not have seasonal, etc., which are kind of marketed for extended and continuous, we can use the traditional pill strips in an extended and continuous manner with the same benefit. The MEC criteria are integral to prescription 1, 2, 3, 4, and I think everyone knows this, and I will not be dwelling on this because I'm more interested in telling about the methods today rather than the particular MEC criteria for each method, because that time does not permit us to do that. But these are some examples of how medical eligibility criteria charts will improve the safety of our prescriptions tremendously. For example, these are the CHC recommendation for use in postpartum women and in older women. And it clearly shows that less than 6 months, the category is 3. That means it's better not to prescribe. But more than 6 months for lactating women, the category becomes 2. Similarly, it will surprise practitioners to know that we can prescribe combined hormonal contraceptives with a category 2 after 40 years of age. In select women, of course, with a lot of clinical nuancing is necessary, contraindications have to be ruled out. There are similar thought processes for venous thromboembolism, for example, dyslipidemia, for example. So this will help us to be very correctly be on the right path for prescription. And this is for the LNG only intrauterine device. And the use of progesterone only contraception, including the device, the implant, the injectable, and the pill. And it is seen that, this is so good. And here, if I can urge you to look at this within 6 weeks postpartum, can you see that we can give them pills, we can give them levonorgestrel, IUCDs, we can give them etronorgestrel implants with a category 2. And as soon as 6 weeks are over, we can even add the pill, the injectable. So there is a huge benefit of knowing about MEC criteria, because then you can be bold to give women contraception in that delicate period of postpartum when they are breastfeeding. This is useful information to have at all times, that we need to know the benefits, because what we know will come out in the dialogue when we are counseling. So we need to know that it will improve, COC will improve menstrual control, it will improve other features of hyperandrogenism, will improve bone health. Of course, it protects against cancers, ovarian, endometrial, colorectal by about 50%, and by being highly effective contraceptives, they reduce maternal mortality rates. The minor side effects are like this. I think many of these side effects women experience even without taking anything during the premenstrual period. Similarly, these minor side effects, they settle down when the woman continues to take the pill. Right. So I think most gynecologists are terrified of venous thromboembolism, arterial thrombosis causing myocardial infarction and stroke. And they feel that prescribing hormones will put the woman at risk and themselves at risk for having prescribed. So it's important to kind of know at all times what is the risk one is undertaking. Now, when it comes to venous thromboembolism and exposure to COC, the incidence is 8 to 10 per 10,000 women years. And the arterial thrombosis is even rarer. It is just 1 to 4 plus 10,000 women years. And then the risk is highest in the first year, and after that it becomes less. Now, with these figures in mind, let us also know that venous thromboembolism in non-users of pills, that means the general population of women, is around actually maybe 5 per 10,000 women years of exposure, even in the general population. And of course, today arterial thrombosis relates to the NCD burden that Indians carry. And also, it is not very low. It may not be 1 to 4 per 10,000, but it may be just 1 per 10,000, but it is not zero, certainly. Now, let us compare this to pregnancy. Pregnancy data for arterial thrombosis is not known, but venous is very well known. And the venous thrombosis, the incidence of venous thrombosis in women is around, in pregnancy is actually spoken of as around 15 to 20 per 10,000 in many years. And that is probably double of what we see in pill users. So pregnancy confers a higher risk of venous thromboembolism, a much higher risk than the use of pills. Progesterone-only pills are also known as mini pills, and some of the formulations are used for emergency contraception, and it can be started at any time, provided the woman is not pregnant. And the benefits and risks are also, very high. They have even fewer problems because they are safe. They are safe for lactating mothers. They can be given, in the 2 to 3 weeks of delivery. Need not wait for 6 months like COC. And of course, spotting PV can be there as a side effect. The risks associated with progesterone-only pills will appear similar to what is COC. And let us just remember that an active breast cancer or a liver disease or a tumor in the liver or an active thrombosis, deep vein thrombosis or an ongoing pulmonary embolism, they all preclude the use of COCs or even POCs. And these are some efficacy and safety of low-dose estrogen, low-dose progesterone combined oral contraceptive pills. And this kind of studies, there are several studies like this, and it shows that very low incidence of side effects and the adverse effects like thrombosis are not mentioned in all these studies. So that means that the incidence must be very, very low. These are kind of summing up slides for SARC versus LARC. SARC are short-acting reversible contraceptives. What we have spoken so far, that means pills, patches, rings, and they are all user dependent, and consistency might be low in usage and higher failure might be there. And women and healthcare providers need increased information for use, as I have been speaking about it, and more nuanced information is required regarding the risks and benefits of reversible contraception, so that the woman can make an informed decision, for better quality of life. So that is for SARC. But when it comes to LARC, it has highest protection rate, highest satisfaction rate, lower failure rate, has got other benefits, and they are estrogen free and therefore more versatile, and also user independent. So that means that LARC methods kind of should be the way forward for Indian communities. These are currently the ones which are available. The copper bearing devices, the progesterone bearing device, the intrauterine device is the DMPA, and this is the implant. So the DMPA of this type of DMPA injection with the receptacle that you are seeing is the subcutaneous one, not the intramuscular, and you can see the subdermal implant. So we go on to efficacy charts, and you can see that the typical and perfect use, the difference is more in the pills and other methods. But when it comes to LARC methods, they are almost similar. That is because the user element of compliance has been removed. And if you can see the implant here, the progesterone only implant, can you see that the failure rate is 0.05%? And this is the lowest failure rate. It is lower than the sterilization. So this is something that we need to remember and we need to comprehend, because it is one of the lowest failure rates. So there are some recommendations for NICE, for LARC by NICE, and by ACOG also, and by Foxy also, and they all endorse LARC methods. This is the injectable Antara. We all know it is available as 150, but for of note is the subcutaneous one, which is 30% less. I have not spent time on how it works. Everyone knows that. But 30% less dosage in the subcutaneous depot. It is only 104 milligrams. Huge benefit of injectables. Very confidential method, reversible, slight delay in return. Does not protect against STI, but does not require any great, eligibility for prescription, and suitable in lactating mothers, and any age it is safe, and any parity it is safe. And there are huge non-contraceptive benefits, anemia, against breast disease, and endometriosis, PID, protection against endometrial cancer, and reduces sickle cell crisis. A lot of non-contraceptive benefits. Few limitations only. Has to be periodically taken, correctly in time, return of fertility slightly delayed, no protection against STIs. And this is the product I was speaking about, the subcutaneous one. It was endorsed few years back by DCGI. Very simple. Healthcare providers can be trained very easily to, and this is today has been included in the government basket of choice. In fact, it is privately less available today, though it is promising to come back. And the advantage is the woman can be trained to take it herself. It conforms very well to self-care, which is going to become more and more popular, self-care in contraception. And the woman can herself inject a LARC method. So what more can you want? These are the potential benefits of the Uniject delivery system. Eco-friendly as well, effective, tolerated. So going forward, some research will show us if the side effects are also less. A few points about the implant. The radiopaque variety has come now, and it is there in the government basket today and is being inserted. So better we all know about it. 2 millimeter and 4 centimeter long, like a matchstick, and at the core will be the etonorgestrel, about 68 milligrams of etonorgestrel, slowly released over 3 years. And a sterile pre-filled applicator, radio opaque, as I already spoke, it is more than 99% effective. And obesity, maybe there is a slight concern and may require an earlier replacement, but not very sure about that. Some medicines interaction, just like COCs, the enzyme inducers can reduce the efficacy, so we need to be aware about that. It predominantly acts by ovulation inhibition, has some effect on the cervix also. Few adverse effects only, and one of them is irregular bleeding, and these are the other ones, but the main adverse reaction is irregular bleeding, which causes a little bit, concern to the mother. There are to the woman. The complications of insertion and removal can happen, but can be very negligible if good training is there. Some women do not deserve this. If there is from active venous thromboembolic disorder, sex steroid sensitive malignancy, hepatic disease, undiagnosed vaginal bleeding, or hypersensitivity to the drug if it is known hypersensitivity. And there can be some interaction with anti-epileptic, antiretroviral drugs, antifungal drugs, etc. When women are on these medications, it's important to tell them that it may not be as efficacious and we have to watch out for failure. Though it is not known, but it is important. Very simple insertion technique, very simple provision required in the OPD, and the insertion area is underarm here, 8 to 10 centimeter from the medial epicondyle, and insertion techniques are simple. Nevertheless, it does require training. Okay, it does require training. This is more about the technical aspect, and the advantages is the moment you remove, women can conceive. That means rapid return. It has some benefit on other menstrual problems like dysmenorrhea. And yes, some benefit is emerging for endometriosis also. So I think I'll have to skip this for interest of time. I don't want to show the video. Is there a follow-up required? Not much. In case women require treatment for or want to share their concern about bleeding, they can come. Of course, a routine follow-up in the present context needs to be encouraged because the method is still new for us. After it has come in its changed form, it is new for us in the private sector. It's very valuable to get our own data about how women are faring with this method. And therefore, the contraindications are very few, almost similar to what we thought with the injectable and the COC, but it is there. And we need to become expert at troubleshooting, have simple solutions for what they want. But if it is not palpable, then it may require some imaging to localize it and remove it. Because if it's not palpable in the place on the underarm where it is inserted, then it requires removal. At all times, the implant should be palpable. So when it comes to women living with HIV, both the injectable and the progesterone and the implant can be used. When they are on drugs, then it can be used with a category 2, the implant, except for drugs like efavirenz, which makes it category 3, and we can look for an alternative. So there are more about special situations, and we must go ahead because it's really not very fitness yet. This is more about subdermal implants and how patient education and informed consent will help in continuation. These are studies on subdermal implants, which are showing very good results, and more studies. Now, this is information on the injectable contraceptive and the injections, DMPA injections, how to counsel for that, and of course, very prevalent in use all over the world. But there is a discontinuation unless counseling is done well because of irregular bleeding and because of amenorrhea. It's important to counsel them better and know that this is the subcutaneous which I was speaking about. Some gynecologists don't like injections because they think that it will make the bone weaker. Well, let me tell you that it's largely unfounded, and it's a very reversible loss which happens, and it can be overcome with an active lifestyle and calcium intake. The only group in which this effect is not well researched is in the adolescents. So if we are giving it in very young girls, then we need to be careful. So who can use DMPA? Almost everybody can use DMPA, even smokers, even endocrine disorders, even gynec disorders, even women on other medications. So this is one area where the injection scores over implant and COC, and that is if women are on anti-tubercular drugs or anti-epileptic drugs or antiretroviral drugs, there is category 1 for injection and category 2 for implant, and so on and so forth. And this, I think I have covered already. And this is also something that I have covered. This is more on the service of DMTA and more on the finer aspects of follow-up. I don't think we have that great time to go through all this. Okay, this is more about a few cases which have been thrown in very, very quickly. That unmarried girl, sexually active, also suspected to be a PCOS. A very non-judgmental counseling and basket of choice is good for her, and emphasis on the dual protection. But also it's important to realize that we cannot take IUCDs out of the basket for her, because even in the nulliparous, it is okay, the young girls, it is okay to provide them with IUCD. It works well sometimes, especially with the very thin ones, the small ones, which are now available for the LNG IUS. About drospirenone containing pills, most of us are convinced that they work very, very well in women with PCOS. And regarding the change from 21/7 to 24/7, I think I did speak about it, that there is a huge benefit of shortening the 7-day hormone-free interval, and adding estrogen to the 7-day hormone-free interval makes the woman a better person actually, because she has less premenstrual problems than when she is on 21/7, and specifically recommended for premenstrual syndrome, the 24 pill strip. Now we have this kind of messages. I'm towards the end of my lecture. We often undermine the value of protecting our women with contraceptives, but let us remember that there is a huge benefit which is beyond our consultation. And UN endorsed contraceptive implants as one of its 13 life-saving commodities as way back as in 2012. And they said that if maternal health, was ensured because of drugs like oxytocin, misoprostol, and magnesium sulfate, then reproductive health interventions, which are life-saving, can be female condom, because it will protect her against HIV, maybe, because we believe only in the male condom for that, but that's what was written. Contraceptive implant, because it will prevent unsafe abortions, and emergency contraception, because it has such a huge benefit of protecting the women in an emergency. So you can see that family planning is life-saving, and it is worldwide acknowledged that it is life-saving. Before I close this, let me put a thought into your heads, especially to the young minds who are listening in. And I started this with the context of population, and I'm ending this with population, because I think we need to be very, very, very kind of aware about where we live, and however much proud we are of our nation, you can see that it is a very dark nation. And when it comes to the chart of population density, there is only one country which is darker, something called Montana in Northern Europe, which doesn't even matter. To us, it matters a great deal, because even though we have 2% of land area, it can shrink rapidly. You can see on all sides we are surrounded by the ocean. So the land tends to move towards the hills. So in centuries it may happen, but India, to have a very great future, should have rapid action pathways for stabilizing population. And the answer is not only by few people advocating contraception like us sitting late in the night and discussing contraception shows our commitment, but the same has to be in your thoughts when you go for your work every day, because almost every woman whom you come across has an unmet need for contraception. Every woman. So as far as maternal death is concerned due to an unsafe abortion, we believe that one preventable death is one too many, and we don't want women dying of unintended pregnancies getting aborted. So family planning alone could bring more benefits to more people at less cost than any other single technology now available to the human race, is what UNICEF says. And thank you very much for a patient hearing. Thanks a lot.
Thank you very much, Dr. Shobha Goody, for enlightening us on such an important topic in a very comprehensive talk. Not just because we as a country are the most populous country in the world, also because we are now encountering, a variety of women stepping into our chambers and asking for contraception, right from the adolescents, with various comorbidities, and to, elderly women who are planning their pregnancies late, and they are demanding more and more of contraception with comorbidities, with venous thromboembolism, etc. So I think this is a very important topic to be addressed, and we are very grateful to you for giving us a overview of the whole topic in such a brief. I know the time was not enough for this vast topic. Thank you very much.
Thank you, Dr. Walia.
Thank you so much, Dr. Shobha Gudi ma'am and
Yeah.
Walia ma'am.
Yeah.
It was a wonderful discussion. Anyone else wants to ask something, they can ask.
It's great to see Dr. Ganpat here. Dr. Ganpat, I hope you remember. We have met in the past. Hi, Prachi. I think it's very late. They must be having their dinner. I think we can wind up if nobody else is there.
No,
Yeah.
everyone is very much with you, ma'am. Everyone was with you.
Thank you, Bhakti. Our audience, I hope they did listen, and the young girls, young people who have joined.
Of course, they are listening.
It's important for them. They are the future, no? They are the future of the country. And they
Yes.
must know how important this service is. I just wanted to say that, many of them want to specialize in endoscopy. They want to do infertility. Some of them want to become oncologists. But as long as they are treating women, they will face this challenge that they have to protect them from unintended pregnancy at any given point of time. So there's a saying which says any woman who is in reproductive age and not tubectomized or hysterectomized has got an unmet need. So for contraception. So let us remember that. Yeah.
So true.
Yeah.
That's the reason exactly why we chose this, because we have covered everything from infertility to gynec cancers.
Yeah.
But then this is something that everyone must know this. So we couldn't skip this.
Yeah, because
we had
every
to-
day, every woman will have a problem. Yeah. And one thing, Dr. Walia, I wanted to add that newer communities are coming up for contraception, and two such. One is the immigrant population, which is developing in every urban area. Urban practitioners are facing those immigrant groups. They come for some time. They are there, in very suboptimal living conditions. They may or may not come to the private practitioners, but sometimes they do come. And then the other group is the LGBT, because this is a very complex group. We don't even know, who will fall pregnant, who will not, and their contraceptive needs are very peculiar. So these are areas which we need to kind of be more. It's a very challenging thing to do, and reproductive health needs for LGBTQ is very poorly understood.
Yes.
So yeah, and I think that we must understand contraception as part of a bigger picture of SRH services, sexual and reproductive health services. That is what happens globally also, and gynecologists have a very big role to play, very diverse role to play, not just childbirth and not just infertility, not just oncology. This is a very, very huge, because it directly impacts quality of life and productivity of the woman. So sexual and reproductive health. So one must become very smart at this in order to have an impact.
Yes, true. Very true.
So I think we'll wind up. Thank you so much.
Yes.
I must thank everyone again.
Yeah. Thank you, ma'am. Thank you for being a part of this wonderful activity. And Corona people, I think we can wind up now.
Thank you so much, ma'am.
Thank you.
Thank you, everyone.
Thank you.
And good night.
Ma'am, good evening, madam, Walia madam. And I would like to request Dr. Pragati Khaladkar madam to give the vote of thanks.
Dr. Dipti, she has already given her vote of thanks before only. Before the start of the lecture only it was done. So,
I think we shall wind up. Excuse me then. Thank you very much. Good night. Good night, Prachi.
Thank you.
Good
Thank
night.
you. Thank you so much, ma'am. Good night.
Oh.
Good night, ma'am.